We are live.
Okay. Good evening, everyone, and welcome to this webinar, AIOS webinar, along with WOS. Basically, the Guru Shishya Parampara in Indian culture has been quite old, and WOS has taken it forward in a big way. And today we are having the webinar where we have put it as unleashing the power of mentor-mentee relation. There is nothing beautiful than seeing your own mentee bloom like a flower and reveal the strength of his knowledge as well, because finally he's your own shadow. Thank you, WS, for mentoring this particular webinar, Dr. Shweta for taking special pains, and Dr. Mohita Sharma for helping us doing this particular webinar. So before we spend much time over any further talk, can I request President of AIOS, Dr. Samar Basak, to address the gathering, and then I would request Dr. Shweta and Dr. Aditi to carry forward the proceedings. Dr. Samar Basak, sir.
Thank you, Prashant. This is a wonderful opportunity to see you all in webinar. This is the concept is beautiful. It is mentor-mentee program by the WS, and we hope I have seen few glimpses of some presentation. I'm hoping that it will be nice, wonderful discussion, and a lot of people will be learning from both the sides, because the mentee usually they teach us also while doing, they ask silly questions and we learn from that silly questions. And that is why the mentor actually used to go back and again teach back. So it is a wonderful experience. I hope this, and good luck to all of you and all the best to all of you. Thank you, Prashant.
Thank you, Basak. And
Prashant, I just wanted to
yes,
just
Dr.
wanted to
Namrata, ma'am,
say
thank you for being with us.
some important highlight of this webinar is you can see almost all of the this is the future of ophthalmology. Almost all of the participants, the mentor and mentees, are going to be women ophthalmologists. And I think one of the unique features is that 99% of the participants here are females, and we always try on all podium that the gender bias should not be there. Even when we send, sessions for international meetings or get sessions from them, the only thing is that there should be, no gender bias. If the panel has 50%, the presenter should also be 50%. But here I think it is 99%, except for Deepak Mishra, and I think for Tushar, and Prashant, of course, and Sir, all of the mentor and mentee are female ophthalmologists. So kudos to everybody and keep it up.
Thank you. Thank you, Dr. Namrata, ma'am. As a father of two daughters, naturally, I see a great future for Indian ophthalmology. And one of them, my daughter, is already into ophthalmology. So I see a great future with all the females dominating the whole society and today's proceedings.
After
Over to
10
you,
years
Dr.
from now.
Shweta, please.
Good evening, everyone. Thank you, Dr. Prashant and Dr. Samar Basak, sir, Namrata, madam, for so kind words. And with these words, we welcome you to the much-awaited webinar jointly hosted by the ARC, AIOS, and Women Ophthalmologist Society, myself, Dr. Shweta Walia, and with me, my co-moderator, Dr. Aditi Agarwal, who is Director of Krishna Netralaya Gurgaon, and who is a corneal surgeon and Secretary of Gurgaon Ophthalmic Society. Today, we'll be the moderators for the webinar, and together we'll explore a series of remarkable videos, presentations highlighting innovative surgical techniques and unique clinical challenges, all framed within the mentor-mentee paradigm. At the outset, we welcome our chairman, AIOS ARC, Dr. Prashant Bawankule, and his team of Dr. Tinku Bali, Dr. Kusturi Bhattacharya, Dr. Srinivas Joshi, Dr. Anga Hurer, Dr. Deepak Mishra, and thank AIOS ARC for providing this platform to the WOS. We also welcome our WOS Secretary, Dr. Mohita Sharma, and thank her for being so motivative, enthusiastic, and encouraging. We've also welcomed our esteemed panel of judges, our President AIOS, Dr. Samar Basak, AIOS Secretary, Dr. Santosh Honawal, Scientific Committee Chairman, Dr. Namrata Sharma, and ARC member, Dr. Anga Haru, Dr. Tinku Bali, and Dr. Deepak Mishra, Dr. Srinivas Joshi, for making this event possible. To guide us through the next step part of the session, let me hand it over to my co-moderator, Dr. Aditi Agarwal. So over to you, Dr. Aditi.
Sorry, I had some problem with my audio. It's okay now. Can you hear me? Am I audible?
Yes,
Yes,
Dr.
you're
Aditi.
audible.
All right, all right. Thank you so much, Dr. Shweta, for that wonderful introduction to the session and setting the stage so well. It's a co-pleasure. It's a pleasure to host this session with Dr. Shweta Walia, who is Professor of Ophthalmology at MGM Medical College, Indore, and also the Chairman Scientific Committee of Madhya Pradesh State Ophthalmic Society. I'm really confident that we are all going to have a really engaging and insightful session today. So we have 11 states participating with us who are going to mesmerize us with amazing videos and depicting a beautiful mentor-mentee relationship. I would like to invite our state heads, Dr. Alpa Atul from Telangana, Dr. Madhvi Rao, Andhra Pradesh, Dr. Meeta Joshi, Madhya Pradesh, Dr. Minakshi Masi, Chhattisgarh, Dr. Arti Nangia, Haryana, Dr. Sudipta Ghosh, West Bengal, Dr. Ranjana Kumar, Bihar, Dr. Suvira Jain, Maharashtra, Dr. Kasturi Bhattacharya, Assam, Dr. Ravinder Malhi, Punjab, and Dr. Devi Aishwarya Das from Odisha. So here we see we have a fantastic bunch of surgeons today, and it's going to be a super fruitful session for all of us. I would like to just share a word about the session layout. So the mentee shall present a 3-minute video, followed by a 2-minute comment from the mentor, and 2 minutes of insight from the state head. So hope you are all ready and ready to showcase your skills and talent. So let's dive in without wasting much time. Our first presenter today is Dr. Sanira, Senior Resident GMC Chhatrapati Sambhaji Nagar, Maharashtra. She will be presenting a video on Bleb revision and needling with mitomycin C. So mentor for the same is Dr. Archana Vare, Professor and Head of the Department GMC Chhatrapati Sambhaji Nagar, Maharashtra. So over to you, Dr. Sanira.
Thank you, ma'am. So it's a case of primary open angle glaucoma, which was a 62-year-old male underwent a phaco triple procedure 6 months back, 4 months back, and the pressures were uncontrolled. So a trial of Bleb needling with mitomycin C was given. It's a simple but tricky maneuver which is done under topical anesthesia. We can see 0.1 to 0.2 ml of 0.02% mitomycin C being injected with a 30 gauge needle right posterior to the bleb. It is massaged out posteriorly away from limbus, and we wait for a couple of minutes so that the drug spreads evenly in the subconjunctival and subtarsal space. A bleb knife is used, which is about 1 millimeter in width, 1.6 millimeters long, and a curved instrument, which is inserted just away from the bleb to enter the bleb area, and a to and fro swiping action is used to swipe off all the adhesions that are formed in the subconjunctival and subtarsal space. Instead of using a bleb knife, few surgeons prefer to use a simple bent 26 gauge needle. In this task, actually, the bleeding chances are more, and hence bleb knife is preferred. A swiping action is done. We can see all the adhesions being released. The original trap flap is identified, and an attempt is made to pass it from one end to let it come from the other end to release the adhesions between the flap. Postoperatively, a gonioscopic examination had revealed a closed ostium for which an attempt was made to slightly pass the bleb knife into the anterior chamber through the sclerostomy site. And we can see the tip of bleb knife coming momentarily into the anterior chamber to open the ostium. As soon as the ostium is open, the bleb starts rising, and we wait for it to form. Whatever defect that we had created is sutured with a single tenonylon suture to achieve a watertight closure. In a circumstance that after opening an ostium, bleeding is likely and antechamber may shallow, so in that case, a paracentesis is created to wash off the bleeding and form the AC. So bleb needling is basically a cardiopulmonary resuscitation given to a failing bleb. It should always be given a try. It is associated with, we have to give realistic expectation to the patient. and we need to give trials to avoid the resurgeries, which is associated with more risk. Thank you. Thank you very much.
That was a beautiful video. We can have comments from the mentor and then followed by the comments from the state head.
Thank you, everyone. I'm Dr. Archana Vare, and I'm thankful to Dr. Subira Jain ma'am for giving us this opportunity. And Samira has presented a Bleb revision video. So Bleb needling was designed to rebuild the failing Blebs and resolve the unfunctional drainage channel with relatively small injuries. Early or late fibrosis of a blade may decrease efficacy of the filtration channel, leading to suboptimal intraocular pressure lowering and eventual failure of filtration surgery. Bleb needling with or without antifibrotic drugs is a relatively safe and effective way to remove the scar tissue and improve filtration. And it can be easily done in the clinic setting on a slit lamp with few long-term complications, and it prevents reoperation. Bleb needling involves cutting through fibrotic tissue in the blade, which reopens the channel. The concurrent use of antifibrotic medications in this procedure helps to prevent the recurrence of fibrosis by decreasing the fibroblast production and the scar tissue formation. However, theoretical risks of Bleb needling, including Bleb leaks, choroidal effusions, suprachoroidal hemorrhage, and endophthalmitis, sway many ophthalmologists to perform Bleb needling exclusively in the operating room or avoid the procedure altogether. So timing selection for Bleb needling after trabeculectomy was considered significant for surgical outcomes in 2 studies. And one study done by Lee et al., they claimed that timing was the only significant risk factor. And the other study, they proved that 3 months after trabeculectomy, needling Bleb can survive up to 12 months. So these are the points that I wanted to share with you all. Thank you.
Right. So I don't want to say too much different, but if I have to sum it up in 4 lines, it's safe, it's effective, it's minimally invasive, and it can be performed with significant ease in a patient who's got a failing or a failed trab. So when you see a failed trab, you just don't need to think, oh God, do I need to do another trab, augmented trab? Do I need to do a tube surgery? It should be considered as a first line of management in a failing trab. What's important is deciding what is the correct timing. Approximately, we should wait for at least 3 months, minimum 3 months, so that all the inflammatory mediators, the fibrosis, all that is set in, let it set in, and then plan it. The 2 approaches are the ab interno and the ab externo. This works very well. Most people are happy doing it with a 25 or a 26 gauge needle. I think a 25 gauge needle is a little sturdier. Making the puncture away from the site of the trab is great. And using antifibrotic agent like mitomycin C could also be used further away, almost about 6 to 7 millimeters away, and wait for a few minutes for it to work. That's also going to prevent the risk of recurrence of failure of this Bleb. And success is determined in cases like this. You got to wait for about 10 days to about 30 days, and you will watch in lowering in the IOP. A lowering of about 10 is considered good in the early postoperative period, that it's going to work. So all of us must not shy away from doing this relatively safe and fairly effective and known, documented, and proven technique of taking care of a trap that's failing. Thank you. We can go to the next.
Thank you, Dr. Suvira. Do we have any questions from the judges? Dr. Deepak, Dr. Tinku, Dr. Prashant, Dr. Samar?
Dr. Deepak is the right person.
Dr. Suvira combined it so well that nothing is left. One thing is only we can say that it is a daycare procedure. You can even do with slit lamps. So each and every fellows or the resident who are watching, they at least do 1 or 2 needling and practice under their mentorship, so that it is a most important step and the initial step by which you can save your blade and the trap. Thank you.
Thank you, sir.
Thank you, Dr. Deepak. Now we move on to the second presenter. Second presenter is also from Maharashtra. She is Dr. Divya Varkheria. She is from the Symbiosis Medical College for Women, and her mentor is Professor and HOD, Dr. Arundhati Pandey. So we welcome Dr. Divya. Are you ready? Unmute yourself.
Muted, I
Dr.
believe,
Divya.
Doctor.
Dr.
Muted.
Divya, unmute yourself.
Yeah, am I audible?
Yes, you're audible.
So good evening, everyone. I'm Dr. Divya Vakharia, and my mentor is Dr. Arundhati Pandey, madam. Today, we will be discussing difficult cases in keratoplasty. To begin with, we have to make a choice of anesthesia. In ideal scenarios, it is general anesthesia. But there are circumstances which do not permit us to go ahead with the general anesthesia. There was a patient which presented to me with fungal corneal abscess with impending corneal perforation. His physical condition could not let me go ahead with the general anesthesia, and I had to go ahead with the subtenance block. I injected 0.5 ml of lignocaine inferonasally through a visco cannula. I could not use a peribulbar block because it was an impending perforation. As we can see, I could finish my case quite smoothly, just as I would have finished it under general anesthesia. There was no difficulty in dissecting the recipient corneal bed. There was no positive pressure or iris bulge that I experienced. I could dissect my recipient bed peacefully, place my graft, and take all the 16 tenonylon sutures. And also, in the end, I sutured my conjunctiva with Vicryl 80. So over to my mentor for this video.
Good evening, everyone. Thank you so much, everyone, for this opportunity, and special thank you to Dr. Suvira ma'am. So yeah, I agree with the Dr. Divya. Generally, we do keratoplasties in GA, but in some cases it is not possible. Even peripulbar anesthesia is also, I mean, in this case, because it was an impending perforation, so it was not possible. And I strongly recommend subtenance in difficult cases where we cannot give a peripulbar or a general anesthesia.
So
Suvira ma'am.
I'd just like to add one point. In the extensive number of keratoplasties I've done, there is surely a significant risk of an expulsive choroidal hemorrhage. I have seen more than a few in my lifetime of doing keratoplasties. So given a choice, each and every case, unless if absolutely unfit for a for a peribulbar block or a subtenon block, should be done under a general anesthetic because it gives you that control. We have a center that doesn't have an ICU setup, so I would also consider shifting him to a center which did. But if you are in a place where there's no such facility, I'm sure a subtenon block would work really well. Next case.
Yes. So during the recipient corneal bed dissection, a lot of us, even after giving intravenous mannitol, preoperatively, intraoperatively, or both, we do get a lot of positive pressure and we see a lot of iris tissue bulging out through the dissected corneal bed. So in such scenarios, we can actually go ahead with placing the graft, suturing it, and then dissecting the remaining corneal bed later. I actually had a case and I tried doing this. It worked out really well for me. And I did do a few cases after that. So over to my mentor.
Yeah, hi. So obviously this case was a little bit tricky and difficult, and I'll go with Dr. Divya. I mean, I agree with her.
All right. So I'll just add a little bit. So when you have an iris prolapse while performing a therapeutic or an optical keratoplasty, we all tend to panic. Sometimes giving intravenous mannitol even at the time of surgery can reduce the intraocular pressure in about 10-15 minutes, and you're able to resume with what you're doing. What you have chosen to do is that when you've dissected about 4 or 5 clock hours of the cornea, you found iris prolapse. So you decided to leave the cornea where it was, the infected cornea, and suture on the graft to get some kind of a closure. I'm sure it's not a bad technique. It would work. But the question I asked you even earlier is, what is the kind of viscoelastic you used here? Now, when you're looking at a cornea over an infected cornea that's partially dissected, you're not looking at a lot of room in the anterior chamber. So I would definitely use, if I were to use this technique, which I believe is good, I would use a dispersive viscoelastic for two reasons. One, to coat my graft, which I want to keep on, and to give me adequate space, working space for be able to then go in there and dissect out the infected cornea and bring it out. Moreover, since you would have taken sutures over an uncut cornea, the area where you've taken the sutures is not going to have a proper graft host interface there. So you retake those sutures, once you've got the entire graft in place and you've removed the infected cornea from underlying the graft, I would retake the sutures in the area overlying the uncut graft to be able to get a good anatomical, match between the host and the recipient. Because many of our therapeutics, we hope that actually work like optical grafts as well. Thank you.
So yeah.
Yeah.
Intraoperatively, while dissecting the recipient corneal bed, we do get a lot of surprises. Like in adherent glaucoma cases, we do get at times attached anterior lens capsule to the adherent glaucoma. Then there are cases of pseudophakic bullous keratopathy or maybe non-infective corneal melts which have decentered or subluxated intraocular lenses. So in either case, the capsule is too weak to hold or position the IOL properly, and pupil is also haywire. So I had a case and I actually used a Prolin suture to do the pupilloplasty. The hack I used was that I tied the IOL haptic in the suture knot while doing the pupilloplasty. Also, in one of the cases, I used the suture knot in a way that it actually acted as a support to position the IOL. So over to my mentor.
Yeah, I would like to add a few points. This technique can be done. The second option is glued IOL can be done because the support, and it is a open sky. I mean it is an open area. So glued IOL can be done in these cases, and when it is an infected case, so there will be no IOL should be put whenever there is a infected cases.
Right. So I'll just, my take on this is, because I've discussed this case earlier with her, that when you're looking at an infected cornea, the fundamental aim of this surgery is actually to remove the infected cornea and put on a clear cornea. Okay, so that you get rid of the infection. That is the primary aim of the surgery. Visual rehabilitation can be dealt with later. When you're looking at an open sky technique, you don't have the comfort of a closed chamber to work with. So if the IOL that you see looks subluxated and looks dangerous that it might fall down or fall in or not get centered, you could remove it. And if you can maintain the posterior capsule intact, that's good enough. If you keep the anterior and the posterior chamber separate because you've got so much infection in the cornea here, I would prefer to then put an IOL at a second sitting, be it a three-piece lens or iris claw or whatever lens I want to do. I wouldn't worry about achieving pseudophakia at the first sitting. I would worry about getting a quiet eye and maintaining the graft clear, controlling the pressure, and then dealing with the secondary IOL should the patient have a decent visual potential. Thank you.
Thank you so much, Suvira ma'am and Arundhati ma'am. I actually got a lot of nice inputs from this presentation and got to learn a lot. Thank you so much for the opportunity.
Yeah,
I
thank you so
think
much.
Dr. Basak is there, one of the leading cornea surgeons of our country. You can have it.
Like I have some comments, and for the first one, that subtenon is always a good technique than perivalvar or retrovalvar if you have to do it other than GA. So in any type of keratoplasty, that is a fantastic. But for second one, intraoperative mannitol doesn't work. So you have to give, if you go back to your basics, you have to give 50 minutes to 1 hour before the surgery started, because that is the time where you will get the peak action of mannitol. So intraoperative Diamox actually helps, but intraoperative mannitol doesn't have any action. This is regarding mannitol injection in any penetrating keratoplasty surgery. That way. Third thing is that in an infective case, when we have two sets of instruments. That is the basic mistake here. we need actually two. One set is to remove the infected tissues and to clear all the hypopion, etc., infected material from them. We separate that set of instrument to other table. We take a new set of instrument and then we suture a new graft, that is optically A grade, B grade, C grade, whatever. Otherwise, if you put that graft over an infected and you are just sliding and corrected, you are keeping that infection, or you are infection in situ and you are putting another graft. That is very wrong idea. So you should not do it. When we are thinking of instrument to be separated and you are putting a graft over an infected graft, that is not to be done. Not to be done. Yes, for optical keratoplasty, you can do it, but what Shubira has said, that sufficient good quality viscoelastic, because there the purpose is different. Optical purpose. Here the purpose is to remove the infection as much as possible. There you can do it, but with compromise of that graft. That is a rare situation. Sometimes we need to do it when there is actually heavy bulging. So before that, what you can do, you can try a pars plana core vitrectomy. I must say that every corneal surgeon should know pars plana approach. Whenever you are cutting the recipient bed, you anticipate there is a bulging.
Exactly.
If you are doing it under local anesthesia, not under GA. GA, you have separate control with GA people. So there you should put a vitrector, dry vitrectomy, just one or two press. Then you will realize that it is like a bowl. So you can do your surgery especially when you do a combined cases where lens tackling in open sky is very difficult.
Yeah.
That is actually severe. So you give one or two paddle at the center. You must practice it, especially with the therapeutic graft where there is nothing to lose. There you have practice in few. I teach this to my fellows that you practice must go on with a little bit core vitrectomy so that intraoperative IOP should be low, and then you could carry out the surgery very nicely and comfortably. Third thing, again, I am along with Subira, the third case. So why you will be thinking of putting an IOL with an infected one? No. ECC, maximum ECC, if at all it is required. We should not make it unicameral. So whenever, if you are trying to, sometimes auto expulsion happens. This we know. Let it with the bed, you close the wound. But if it is partially indeed or your capsule is ruptured or cut during trephination, sometimes it happens, then you just do a simple ECC, clean the cortex because these are all soft lenses, and clean it, close the wound, and you do at all if you want to do a procedure of secondary IOL is a good choice. But with infection, never think of putting any IOL because you will be creating more problem. So these are my few points along with this presentation.
Thank you.
Thank you, sir.
Thank you. So I think let's move on. We have 13 speakers to have their videos today. So let's move on. In interest of time, let's move to the next topic. Now, the next two videos are from Haryana. So first, I invite Dr. Garima Satija, who is an associate consultant at Fortis Eye Institute, Gurgaon. She'll be presenting a video on subluxated cataract. The mentor is Dr. Parul Sharma, who's director and head, Fortis Eye Institute, Fortis, Gurgaon. Yes, over to you, Dr. Garima.
Good evening, everyone. Ma'am, am I audible?
Yes, you are.
And my screen is visible, ma'am?
Yes, it is. Go ahead.
Okay. So good evening, everyone. I'll be presenting a case of 42-year-old male who presented with a history of blunt trauma 1 year back with a subluxated cataract of 4 clock hours from 6 to 10 o'clock and with vision of 6:36. So we decided to go ahead with the cataract surgery for this patient. To begin with, we have made the side port incision and the central to main entry 2.2 mm. Now we are doing a rhexis, a small rhexis, keeping in mind it is in the center of the bag, and we do not press the zonule. We do not try to stress the zonules. We do a gentle and a controlled IA so as to prevent any further dialysis. And now we are placing 2 capsular hooks so as to give some strength to the bag. Now in this, we have to be careful while doing phaco that we do a slow motion phaco where all the fluid parameters are kept low and a direct chop technique is followed and all the nuclear fragments are emulsified, keeping them in the safe area. So important, then we inject the visco first and then remove the probe. So while doing a gentle INA, we are using a bimanual cannula. Now we are inserting a capsular tension ring and keeping the ring in the area of the zonular dehiscence and the eyelets away from it. Now we remove the capsular hooks. We notice that the bag is still not stable, so we decide to place a Ahmed capsular tension segment using a Gore-Tex 80 suture. So basically, this suture has got a curved needle. So we try to first straighten it using the 2 needle holders, and then using a railroading technique, we'll be placing it inside the eye. So first, the suture is placed in this center eyelet loop, and the segment is placed inside the bag. So now we'll the place where we had created a conjunctival flap, we place a 25 gauge needle by putting it first perpendicular and then parallel to the iris. And now we have to feed this Gore-Tex suture inside this needle. So very carefully we try to put this needle and feed it into the 25 gauge needle and pull the Gore-Tex arm. And similarly, now we'll be doing it for the other end of the needle of the Gore-Tex suture. In this case, if the Gore-Tex is not available, we can even use Prolene 90 suture, but it is not biodegradable. So we usually prefer to use Gore-Tex suture. Now we have to pull this suture to adjust the segment inside the bag. And then after once the segment is adjusted, then we tie the knot of the suture to 1 knot is placed. Now we are placing a monofocal monofocal IOL in the center of the bag, and while dialing, we have to see that the hooks that the haptics are placed in the area of the zonular dialysis. Now we can see that the IOL is well centered. We hydrate the ports, inject pylo, and then remove it. So we close the knots by covering it with tenons and the conjunctiva using a cautery. Since the IOL is well centered and even after the 1 week post-op follow-up, the patient is having a vision of 6/6 vision. Thank you.
Very nice. It's a very nice video. Dr. Parul, you would want to add on some words?
Yeah, so this case has been highlighted to discuss especially for beginners on this journey. I would like to highlight that a thorough evaluation is very important because on slit lamp sometimes we get misguided by the degree of subluxation. So ideally when you have subluxated cataract, take the patient to the OT, make them lie supine and see the extent of subluxation under the microscope so that you can prepare depending on the degree of subluxation. So if it is 3 clock hours, you will get away by just doing a capsular tension ring. But if it is more than 3 clock hours, you would need another scleral holding device like a capsular tension ring. If it is larger than that, then a Sionese ring or a double Sionese rings. So very well presented, Garima, and I would urge all the people who are starting on this journey is to be very well prepared also in terms of your instrumentation. So have your list of what sutures you are going to use, which scleral segment devices are you going to use, which lenses are you going to use. Always have standby lenses. So for example, if you lose your bag at some point or it extends, then you should be able to have a iris fixated or a secondary IOL suture. Always keep vitrectomy in hand because you don't know which way it's going to go. So preparing right, having all your instruments ready, doing it under block, talking to your seniors, looking at a lot of surgical videos. ARC and AIOS has so many golden videos out there. When we started subluxated, I must have gone through at least 15 subluxated cataracts. So evaluate right, prepare properly, and careful execution, especially in any kind of subluxation. Low fluidics are very important. So your phaco power vacuum should be such that there are no stress on the zonules. Capsular hooks are a big saver in any kind of subluxated lag. I tend to use the capsular tension rings a little, ring a little later, because early in the subluxate cataract, if there is a PCR, then we lose your CTR. So I tend to use the CTRs later. Also, initially, if you put, then the cortex removal is difficult. And a tip there is to use tangential instead of just pulling. So hold the bag with the hook, low fluidics phaco, and then plan your IOL depending on the stability of your bag.
Very nice. Dr. Aarti, you would like to add some words?
I would really congratulate the speaker and the discussant. Both of them appropriately put all the points across. Very good video, and I think a very apt condition. I'll just add that femto laser is a very useful tool in subluxated lenses as well. If you can, if the lens, before doing any of these rings and the tension rings, putting inside, because we can't open the eye before taking our femto. Femto is very handy, and it's supposed to be an indication in subluxated lenses, where if you go by the capsule centered rexes, then if you are able to achieve that, the rest of the procedures being, as Parul said, low fluidics, phaco energy, depending on if it is not a very hard cataract, we can get away with a very good surgery. So I'll just add on the point of a femto laser can be considered in such kind of subluxated lenses. Great, Garima. I think I'm happy.
Thank you, ma'am.
Haryana has 2 presentations, so I'm
Thank
so
you,
happy.
ma'am.
Yeah, right.
Thank you, Dr. Aarti and Haryana team. And now we move on to the presentation of Dr. Nidhi Sharma. Dr. Nidhi, are you ready?
Yes, ma'am.
She'll be presenting on scar modeling, followed by a definitive management of cicatricial ectropion. She is senior resident from PGI Rohtak, and her mentor is Dr. Urmil Chawla, who is professor at PGIMS Rohtak. Over to you, Dr. Nidhi Sharma.
Good evening, everyone. Am I audible, ma'am?
Yes, you are audible.
You are.
Is my screen visible, ma'am? Should I start?
Please do.
Thank you so much.
Cicatricial ectropion is usually associated with shortening of anterior lamina following injury, or in some medical cases like tumor and ichthyosis. Medical management includes lubrication, lead taping, and scar remodeling, while the definitive management remains surgery. For scar remodeling, 50 mg per ml of 5-fluorouracil is given into and under the scar after injecting 2% lignocaine. Lignocaine is given to prevent side effects like pain and tissue ulceration. The injection is given with the help of a 26-gauge needle at multiple sites to distribute the drug evenly. It can be repeated every 2 to 4 weeks. 0.9 ml of FU can also be combined with 0.1 ml of 40 mg per ml of triamcinolone acetate for better results. 4 to 6 injections can be given. Mild cases of lack of ophthalmos, blood contour abnormalities, and cicatricial ectropion can be treated with 5-FE alone, and 95% of patients report decrease in stretch effect following the injection. While in advanced cases after giving 5-FU, we proceed with full thickness skin grafting. 3-stay sutures are passed through the lower lid with 4-0 silk. This is to fix the lower lid and hold it. Incision is given 2 mm below and parallel to the lid margin to release the cicatrization. The dimension of the wound is measured with caliper forceps. The post-auricular area is then marked using 1 mm larger measurement on the caliper forceps. Skin incision is given along the marking, taking full care that the underlying structures are not harmed. Skin graft is then removed from the site. The subcutaneous fat underlying the skin graft is then excised carefully. Graft is placed on the wound and sutured with 6-0 silk. The lateral margins are sutured first. Here we see the graft margins are sutured. The post-auricular side from where the graft was taken is then sutured with 6-0 silk. At the end, 3 to 4 stab incisions are made to prevent hematoma formation, and a bolster is placed on the graft and sutured with 4-stay sutures. This helps to prevent hematoma formation later on under the graft, which may lead to graft failure. Bolster is usually removed 5 days after surgery. In a few days after healing, the color of the graft will become identical to the surrounding tissue. Here we see another happy patient with a desirable result. This is another patient where full thickness skin graft was combined with LTS procedure. Thank you so much.
Thank you, Dr. Nidhi. Dr. Urmil, your comments?
Yeah, just a minute. Okay, slideshow. Just a second. In fact, I would like to thank ARC for the opportunity. And she has told cicatricial ectropion. It is an aesthetically disfiguring condition leading to functional symptoms, could be epiphora keratitis, and it is definitely challenging for the oculoplastic surgeon. Try to point out certain things which have not been able to be covered in the video, like temporary procedures are lubrication, horizontal taping, or the scar modulation, which has more important than the definitive management, I would say. Remodeling can be done with 5-FU, and because it is decreases the fibroblast proliferation and causes inhibition of collagen, it reduces the scar formation. And both options are there, either individually 5-FU and TCA alone, or a combination can be used. Results have been seen to be good to excellent with only 5-FU monotherapy, but better have been with TCA plus 5-FU in the ratio of 1:1 in 96% of the patients we find. And each visit, we should evaluate for redness, swelling, tissue inflammation, and other side effects. I'm just giving you a series of patients that I treated with a combination of 5-FU and TCA, and you can see the results of the cicatricial ectropion. These are after 3 to 4 injections. So you can see the pictures before and after. In certain cases, you will also see that there's entire scar gets volumalized and it gives a good appearance. This patient specifically, she had a little lag of thalamus also because of the retraction, and we were able to correct the lag of thalamus. This again, another patient. So these were the patients which showed definite improvement after the scar modulation. So my message definitely is, don't just jump to the definitive management of cicatricial ectropion. Please wait and go ahead with the scar modulation. You definitely have better results. In some of the cases, you might not even need to go to the definitive management, but in advanced cases like these, definitely you have to go, and all the patients are generally satisfied. And the best thing is that even after the single injection that is given, when they come back after 1 week, there is such a good effect. They have such less tightening effect. Most of them will say कि हमें खिंचावट नहीं feel हो रही, and they are very well relieved and happy to go ahead with the second injection. So it definitely helps even otherwise and before surgery also, because it makes the scar soft. And so definitive management in such other cases, advanced, where only modulation cannot help, is the full thickness skin graft. And the key takeaways are the surgery that has been shown that graft size should be 1 to 2 millimeter larger, or donor sites can be different depending upon the size needed. It can be the upper eyelid or retroauricular area. If the graft site needed is large, you can use the supraclavicular area also. Stab incisions in the end are must to prevent hematoma. One should not miss them. Bolster again is a must to give pressure on the graft and prevent mobilization and shearing forces, decrease the risk of infection. Rather, we should keep it for 48 hours and the bandage should be opened after 48 hours. Frost suture is a must, should be kept for at least 2 to 3 weeks to keep traction to the lid. You just don't leave it without traction, otherwise it may definitely slide down again. So these were the results of after 4 days. You can see after 4 weeks, after 6 weeks, the graft changes its color and soon it becomes to the normalized. So it is a presentation different from the routine cataract. I hope it would be helpful. My takeaway message is, don't jump to the surgery. Please wait, give a time for scar modulation and then only go ahead. Thank you so much.
We can
Thank
have
you,
Dr. Kam's comment for ARC member and oculoplastic surgeon.
Thank you very much, Dr. Urmil and your team. You have really presented well. Yes, I also agree with you that 5-FU and triamcinolone does help. But I would like to mention one point. What I have been doing very recently for the last 1 year is the nanofat grafting. For scar, the nanofat is just excellent because this nanofat contains the SPF, the stromal vascular factor, with all the growth factors. So you can get a result, beautiful result, very early after the surgery, number one. And number two, when you go for full thickness skin graft, quilting surgery are very important, especially when you have when you need to give a larger fat graft. You have nicely shown the stab incision to prevent hematoma, but sometimes what happens, when you put the stab, the itself may lead to a hematoma, right? So if you put a quilting surgery, like the purse string type of sutures, it really gives a very good graft alignment and the graft acceptance. But congratulations to you and your team. Very nice presentation.
Thank you, ma'am. Thank you so much. Thank you.
Thank you, Dr. Kasturi. Any comments from Dr. Aarti, the state head?
Very well presented, Nidhi and Dr. Urmil. I think you're a stalwart in this particular procedure. The graft is taken from the buccal mucosa?
No, ma'am. Generally, it's a skin graft. So we take it from the intraocular, supraclavicular area inside the arm length. Also can be taken. Abdomen skin can also be taken. These are this. For this, we don't use the buccal. Buccal mucosa is used for many oculoplastic surgeons, but not for this particular one.
Yes, and I guess 5 FU is an antimetabolite. Do you do any kind of systemic investigations to just
Yeah, routine investigations, because it is not, it's first thing is very cheap, very affordable. Just the vial is just costing 50 rupees. So it's very affordable to the patient. They are willing with the 4 injections. After, we generally give after 2 to 3 weeks, depending, and regular follow-up of the patient with photograph record. And that really helps. And generally, no side effects are seen. Once I have seen telangiectasis in one of the cases, but that too gets managed easily.
Do you use it in involutional ones also, the aging ones?
We can. Basically, it is meant for releasing the scar, ma'am. If the involutional cause is somewhere scarring is involved, it can be used. Otherwise, not. There's no point using.
I think excellent. Overall, just one feed. I mean, one kind of sharing of an experience I had very recently. I had a patient who was a cook in Radisson Hotel, and he exposed his face with a extreme amount of steam because the whole bowl just kind of spilled over. So because of the steam, he got lids and whole of the cornea burn. It was a steam burn, so it wasn't that bad. But to avoid, I just told him to sweep the furnaces with not having the scar made. So this just a take home message from the PG Times. We know that whenever this kind of a burn happens, you can use a tongue shaped lid, retractor to put it, and or otherwise just a Johnson's butt sweep. So this is a handy tip for, I'm sure you are tackling the final results, but this can be very handy for burn cases.
I'm like cataract is very, I mean, vision aa jati hai. Oculoplasty gives cosmetic improvement, and the patients are so happy if you give good results, and we are also extremely happy if our results are good. Thank
I
you so
think
much.
Dr. Kasturi, you are doing a wonderful job, because oculoplasty is plastic surgery, which really gives the shape to the whatever kind of scars one can have around the
Dr.
eye.
Kasturi is on the top notch. We need to learn a lot to reach there.
Thank you so much. Thank you
to
so
have
much
her-
for the kind words. Yeah. But very nice presentation, Dr. Urmil, and your mentee. She's
Thank you.
really good and presented very well.
Thank you, ma'am. Thank you so much. Thank you.
Thank you.
Great. So since we are in the oculoplasty mahol, let's move to Dr. Kasturi Bhattacharya's case. She's the mentor for the case. I would like to invite Vatika Bharadwaj, who's a fellow in Sri Shankaradeva Netralaya, Guwahati, and the mentor is Dr. Kasturi. Welcome, Dr. Vatika.
Good evening to all the esteemed judges and panelists attending the Zoom meeting. Today, is my screen visible?
Yes.
Yeah, it's visible.
Today, I'm pleased to present my video on navigation guided protocol in surgical management of complex orbital and optic canal fractures.
Full screen. Yeah.
Feeling lost operating orbital fractures is like feeling lost at sea, as not everyone gets Jack Sparrow's magic compass. Navigation guided system is like your lighthouse. This video describes navigation guided protocol in surgical management of complex orbital fractures. The data is preloaded in the form of CT MRI into the console system, which uses GPS to provide real-time updates like in-location maps. In simpler words, just as a satellite provides real-time updates to guide someone to their precise destination, this system assists surgeons in pinpointing the exact location of interest and synchronizes the instrument's positions with pre-obtained CT images of the patient's anatomy. This navigation-guided protocol can be used in management of various complex orbital fractures and also Leyford and NOA fractures. This video shows navigation registration, aligning the patient's real-time anatomy with the CT scan. Next, instrument verification ensures that the tracer tip's position inside the orbit is accurately tracked on 3D CT images for precise orbital navigation during surgery. The software provides real-time data interpretation using color-coded overlays to differentiate structures within the orbital cavity. This helps identify fractures and isolate damaged areas from healthy tissues. In addition to this, the software has feature of auto-segmentation, which allows precise isolation of structures like bones and tissues, enabling focused planning and avoiding nearby critical areas. The most unique is the mirroring feature, which replicates the unaffected healthy side as a template over the fractured side, restoring and guiding symmetry by measuring defects, assessing tissue herniation, and mapping bone positioning. Together, these tools enhance surgical precision and ensure accurate reconstruction of the fractured orbit. This surgical video demonstrates orbital floor fracture repair using navigation. Initially, the probe enters the maxillary sinus through the defect. After identifying defect, an MTB implant is placed to cover and reposition herniated contents. An FDT test confirms tissue repositioning. Post-repair, the probe no longer enters the sinus, indicating precise closure. Post-operative results are satisfactory, showing improved enophthalmos, EOM movements, and implant placement. The software also uses advanced 3D imaging technology to convert to D-diacom images from CT scans into 3D anatomical models. This allows for detailed visualization of the patient's unique orbital structure, extent of fractures, creation of 3D models of the fractures, and use of new patient-specific implants. But this is not the end. The future holds advent of newer innovations that could lead to faster recovery times, reduced risks, and better outcomes in orbital fracture repair, making treatment more effective. Thank you.
So I'm both the state head and also the mentor. So 2 minutes as a state head and 2 minutes as a mentor. Okay. So let me congratulate WOS and ARC for this beautiful mentor-mentee relationship program, because I feel that this mentor-mentee relationship is such a dynamic and transformative bond which fosters learning, growth, and a mutual enrichment. So this is basically, I could say, all the beautiful mentors and mentee here. So this is basically a partnership of trust, respect, and a shared commitment, which helps everyone to grow. Both the mentee is also growing and also the mentor, and also involving the communities that they belong. So back to the presentation by Dr. Vatika, she has shown that the navigation guided surgery in different types of complex fracture, and we feel that this navigation where we use the images of CT, MRI or MRI is basically, it is representing an advancement in the surgery which makes everyone a safe surgeon. Like what we want the future generation to be very safe. So this system is basically a real-time imaging system, and the software is so up to date, like I should say the state of the art software. So it enhances the surgeon to perform very intricate procedures on very delicate structures, and most important, with so much of precision, accuracy, and safety. So exactly what is this navigation surgery? It is like a pathway visualization. It guides the surgeon along a predefined pathway, ensuring that every step, every procedure that they are doing within that small conical orbit, they are delivering safe procedures, reducing complication like injury to some of the vital structures, to the nerve, and also bleeding. But I like to mention here, for the benefit of all the young ophthalmologists, that this navigation is not only used for orbit today, it is used for many other procedures, like Dr. Prashant is here. It is also used for retinal procedures, especially for the macular hole surgery. The glaucoma, the first presentation on glaucoma, navigation is also used in glaucoma surgery, specifically for the guided canaloplasty, and sometimes also for very difficult intraocular lens placement. There are also studies where it is being used for DMEK and the DELC surgery for the precise positioning of the graft. So in conclusion, I like to mention that navigation-guided surgery in ophthalmology is definitely a groundbreaking innovative surgery which addresses the challenge of precision and complexity in the eye surgery. Most important, it enhances visualization, decreases the risk, optimizes the outcome, and very important that it offers the patients a safer procedure and a better prognosis. So with this, I'd like to mention that we know that technology has today become the cornerstone for all modern medical practice. So this navigation has also become a very important, what is a guide to be a very safe surgeon, especially when we work somewhere in the apex or for a very complicated fracture repair. Thank you very much.
Thank you.
Thank you, Dr. Kasturi. Any questions from the judges, or we move on to next presenter? I think we'll move to next presenter. Next presenter is Dr. Snehal Panpate. She is fellow from Medivision Eye Care Center, Hyderabad, and her mentor is Dr. Charumita J. Puranik, who is a senior cornea consultant, and she'll be presenting surgical pearls for sutureless DSEK. Dr. Snehal?
Yes, exactly. Is it visible?
Yes, it is visible. It is visible.
One second, 1 second. Is it visible to everyone? Hello?
Yeah, it's visible. You can proceed, Snehal.
Yeah. Good evening, everyone. I'm Dr. Snehal from Medivision Eye Hospital, Hyderabad. The basic principles of sutureless DSEK is that all entry ports must be self-sealing and we deposit our graft over the inner lip of the main wound. The first pearl is that all ports must be self-sealed and we make a long and compact wound just enough to insert an irrigating cannula. The construction of the main wound must follow all the basic principles of a good traplanar phaco incision. Use only side port or infusion ports for manipulation purpose. Never use main incision to prevent expulsion of the graft. Next, we need to make an extremely thin lenticule so that it may be inserted through a small incision. With practice, it is possible to achieve consistently thin grafts without entering the anterior chamber. Ease of dissection is indicative of a deeper plane, since posterior stromal fibers are widely separated. We want to highlight the technique of a double locking the inner lip of the main wound. So gentle tapping movements in a partially filled globe permits positioning the graft such that it seals the main wound as well as the side port. And this can be done by using a reverse Sinskey hook. A full chamber bubble can then be achieved by an injection through the long irrigation port or using a 30 gauge needle. It's important to know when not to attempt a sutureless DSEK, such as cases where iron needs to be exchanged, or in a DSEK post-failure of penetrating keratoplasty cannot sustain a full chamber air bubble without sutures, where a scleral incision is ideal. In conclusions, self-sealing incisions are large enough for smooth insertion of the lenticule and small enough for tectonic stability are ideal. Double seal the incision by lenticle repositioning and gentle graft manipulation. And last but not the least, know when suturing is must. Thank you.
Nice
Thank you, Dr.
points.
Snehal.
Yeah, good points shared by Snehal. So Charuta, Dr. Charuta, you would like to have your comments?
Yeah, absolutely. So thank you again. Special thanks to Wos, AIOS, Dr. Mohita, Dr. Alpa, Prashant, and everyone for this platform. So as we saw, the incision form is actually paramount for the success of a sutureless surgery. And of course, the usual tenets of a straight incision coming in straight out is holds true. And I would say that actually a longer tunnel, which generally is considered as a poor form, for a phaco incision is actually very useful for us for the AC port entry. So we use a 23 gauge irrigating cannula, which is actually very good since we are not concerned of overlocking here, and we just needed to insert the air bubble and not allow it to track back. So again, like we have seen in the ASOCTs, the incision has to be symmetrical even in the entry. So the roof and the floor have to be almost of equal thickness as well. And some of our clinical outcomes we are seeing here, wherein the overlap is still seen. In some of our cases, we've seen that the graft has shifted a little bit, but it's enough to sustain the pressure at least intraoperatively for the 8 minutes. So this is another case. This incision is seeing superiorly. Now, I'd like to continue with a video, and that the irrigation port is actually very useful. So this is a case of bullous keratopathy again, surgery done elsewhere. So this is the long irrigating port which Dr. Sneha has very nicely presented, and the irrigating port allows us to do a very clean desmet stripping, as well as if you can see here, it's allowing me to maneuver the eyeball as well to the required. Sometimes we feel like moving the eyeball towards us to get a better glow, and rather than using the forceps, it helps us also to have a full pressure chamber and then make an entry as well. So this is very important because we don't want to use viscoelastic agent in these cases unless there is a pre-existing PCR or we want to do a cortical wash as well.
I think we can have comment from Dr. Samar Basak, who is the highest number of DSEK DMEK in our country, as well as from Dr. Namrata Sharma.
So basically, it is a very nice technique and long time. Actually, I am using sutureless technique for 18 years. So since inception, but my incision is clear corneal tunnel. Basically, to give corneal tunnel, we know the astigmatism point of view. Here, the problem is astigmatism. So here, the incision size is, I suppose it is around 5 millimeter size. So 5 millimeter size, whatever you put suture or not, that will create more astigmatism than if you make a sclerocorneal tunnel. And again, as I like SICS tunnel, you don't require suture most of the time. But suture is required, as Charuta has pointed out, and also the previous presenter, that SFIL, yes, where there is a chance of collapsing of the globe, like SFIL cases, post-vitrectomized, post-PK keratoplasty, then your aphakic cases, where we see there is a chance of, or there are multiple surgeries happening, like 2-3 times you are doing surgery, repeat DSEK or something like that, where you do not have like multiple incision in the similar plane. Then you have to go other side, and sometimes it is also difficult because side spot are creating problem. So the sclerocorneal tunnel is a very beautiful technique, and you can have actually the graft size may be little larger if you give sclerocorneal tunnel, because that we are also overriding in some of the cases, but we do not override much because there is a chance of eccentricity of the graft. And from DSEK point of view, though manual DSEK is more uniform in thickness than automated, which is thicker in the periphery, there are chances of more higher order aberration from the posterior surface. So this is sutureless DSEK is highly doable, and it is highly practicable also, and the technique is described very nice.
Thank you, sir. So thin grafts, actually, we are placing copious amount of viscal heel on and then inserting through the around 3.5 millimeter it comes. If the graft is thin, then around 3.5. Otherwise, if it is thick, then of course, like you said, we have to extend it more a little bit.
Now that is one point, but again, thin graft, you have a chance of the triple fold of the graft, unless you have a very good AC maintainer and you do not have control over the AC maintainer. That sometimes it happens trifolding of the graft, then you have to mark the graft very nicely so that you could spread it in a proper direction. That way it is fine. So the concept of DSEK is that the larger the graft, the less amount of endothelial cell loss. A lot of studies has been published. So 5 to 6 millimeter graft size is better unless we use the Busin glide, where the graft configuration is not folding or it is not crushing within the tunnel. When you are making a longer tunnel, then there is a chance of more crushing of the tissue within the tunnel. That will not happen if your wound size is 5. I give always 5.5 or 6 millimeter because I don't want any crushing of the grafts. That's why the graft survival and post-operative after 15 years endothelial cell count is going good. So from that point, and that's why I go for SICS kind of incision, so that I know it is self-sealing, it is like frown incision, and everything is perfectly planned. So this is also a good technique, but you should try with a little posterior, like you showed one scleral one. That is also
So
good.
for the post-keratoplasty, we did.
Yeah, posterior, you need to go scleral. But other surgeries where the cornea is smaller in size, like in Bengal, this cornea is always smaller, like 9.5, 10 millimeter. Then we have to be very careful about the sizing of the graft.
So sometimes we already have an incision present. In those cases, then we are just avoiding and going in another direction. The previous incision of
that's
or
why that multiple, so it is
surgeries,
the second surgery, second DSEK, re-DSEK, then you have more problem.
Yes.
So you have to carefully select the site of clear corneal, then it will be a more problematic. If you choose scleral, you have plenty of space to choose from any place.
Resurgery is a complete
Resurgery.
no-no for clear
Yes,
cornea.
yes, absolutely.
Thank you so much for the insights.
Great. So should we move on to the next presenter? So we'll be moving on to Dr. Harika Rigani. She is going to present on real challenges in oculoplasty. She's from Eye Focus Super Specialty Eye Hospital, and her mentor is Dr. Y. Sujata Savitri Netralay. So over to you, Dr. Harika.
Thank you, ma'am. At the outset, I would like to thank AOS and WOS for giving us this opportunity.
A spasm is defined as sudden involuntary muscular contraction or convulsive movement. Facial spasms can be classified as hemifacial spasm, blepharospasm, oromandibular dystonia, facial myokemia, tardive dyskinesia, chorea, psychogenic facial spasm, and myoclonus. The syndromic associations of the spasm include neurovascular compression syndrome and Mead syndrome. Neurovascular compression syndrome is seen when a facial nerve is compressed, commonly by a branch from anterior inferior cerebellar artery, resulting in hemifacial spasm. In this video, we look at the clinical presentation and the management options in cases of Mead syndrome. Mead syndrome is a combination of blepharospasm and oromandibular dystonia. The main symptoms include involuntary blinking and chin thrusting. Some patients may experience excessive tongue protrusion, squinting, light sensitivity, and muddled speech. Associated platysma and laryngeal dystonia is seen in few cases. These dystonic spasms often get provoked by certain activities such as talking, chewing, or biting. Apraxia of lid opening is a common association which is characterized by the inability to initiate voluntary eyelid opening. Botulinum toxin A injections are the treatment of choice which act presynaptically by inhibiting the release of acetylcholine at the neuromuscular junction, causing a dose-related denervation and paralysis of striate muscle. A maximum safe dose of 100 to 125 units was described in the literature. However, frequent hospital visits and the finances are a concern. Orbicularis myectomy is an excellent surgical procedure where the preseptal and pretarsal orbicularis muscle fibers are excised. Some surgeons also remove the pretarsal orbicularis and release the other eyelid protractors, that is, procerus and corrugator muscles. More often, these cases are also associated with blepharotosis. Hence, combining it with blepharoplasty and levator reinsertion would give the best results. Few patients might need the botulinum A injections after the surgical procedure as well, but with lesser doses and longer duration. Meeks syndrome can hamper day-to-day activities of the patient, leading to social embarrassment and stigma. Limited orbicularis myectomy is an excellent option in these cases, providing long-lasting functional and aesthetic outcomes. For a surgeon, relieving the patients from their long-term grief is extremely gratifying.
Thank you so much.
We can have comments from Dr. Sujata.
Yeah. First of all, I'm thanking AOS and Wos for giving me this opportunity. And with essential blepharospasm and mixed syndrome patients are very unfortunate patients, suffering a lot with very minimal choices of treatment. And Botox treatment is very good. And here Harika showed the treatment procedure very well. And the results also very good. And post-operative results like after doing orbicular myectomy also, very good results she showed. But there are some disadvantages with these Botox injections, like it's a short duration of action, like 6 to 8 weeks only, and repeated injections are needed. And the cost of injection also is another drawback. But for the severely affected patients, the results are very good. And she showed very good results also with the injection and also with the surgery. One thing I noticed with all these blepharospasm patients, ocular hypertension I noticed. I recorded many of the cases having higher side of intraocular pressure rise. And after treating with anti-glaucoma medication also, they are very well responding to anti-glaucoma treatment. And this, I think everybody should take home. And when the patient comes with blepharospasm, I think we all should check at least once exclude the glaucoma status. And surgical management, even I have done some few cases and with very good results with orbicularis myectomy. Thank you, Harika, and thank you everybody for giving me this opportunity and nice presentation.
Dr. Madhvi would like to give her comments.
Yeah, I thank AOS, ARC, and Wos for giving us this chance. Thank you, Dr. Harika, for that very nice presentation, and Sujata Madam for your valuable inputs. I was wondering as to what will I talk regarding this oculoplasty topic, being a cataract and refractive surgeon. But after seeing this, I'm sure many other people like me, it has been a real eye-opener for general ophthalmologists and also any other subspecialty. We can guide our patients properly that not only Botox, but also surgery as a very good viable option with very satisfying results, helping these particular subset of patients who are looking for some panacea for this distressing condition of theirs. The results are definitely giving them a very good cosmesis, more confidence, and a better quality of life. Very nice presentation. Thanks.
Thank you.
Before we proceed, I would also want to invite Dr. Alpa Atul for her comments. We missed her comments on the previous talk. Dr. Alpa Atul for the sutureless DSEK session video that we had. Dr. Alpa is here?
I think she's not there.
All
We'll
right.
proceed for the next presenter, and then we can ask her later to do it. So next presentation is by Dr. Niharika Arya, Unveiling the Unexpected Post-Operative Capsular Distension Syndrome. Dr. Niharika Arya is Assistant Professor at MGM Medical College, Indore, and her mentor is Dr. Manushree Sharma, who is also Assistant Professor at MGM Medical College, Indore. And the state head is Dr. Meeta Joshi. So, Dr. Niharika, are you ready? Please unmute yourself and share your video.
So, ma'am, am I audible?
Yes, you are audible and video playing. Please start.
Yes. I thanks ARC and the Women Ophthalmic Society for giving me this opportunity. So I'm presenting a case of 51-year-old male patients who came with a gradual, progressive, painful diminution of vision in the right eye, which was associated with a mild redness since 2 months. So, by the history, 6 months back, he underwent a right eye cataract surgery, and 4 months later, he develops a diminution of vision, which was gradual, progressive, painful, and associated with the redness and watering. He is already on the 4 anti-glaucoma medications, so no response was there. So he came to us. General examination and the systemic examinations were within normal limit. On the examination of the right eye, we found that there is a best corrected visual acuity is 6/36 with the corneal edema is present. Peripheral iridotomy present at a 2 o'clock positions. IOL is in place, but there is an increased distance between the IOL and the posterior capsule with the turbid fluid. Pressure by the non-contact tonometer was 36 millimeters of the mercury. So, and on the examination of the left eye, the best corrected visual acuity was 6/36, and with the nucleus crosses grade 3, cortical spooks, and the posterior subcapsular cataract. Pressure by the non-contact tonometer was 16 millimeters of the mercury. Fundus of the right eye was clear, media was clear, but there is a vertical curvedness ratio of 0.7 with the nasalization, and the bayoneting sign was present. NRR thinning in infero-nasal quadrant. Rest findings were within normal limits. On the fundus of the left eye, the media was hazy due to lenticular opacity, and the rest findings were within normal limit. So we make a differentials of the capsular bag distension syndrome, late onset endophthalmitis, UGA syndrome, malignant glaucoma, and the steroid-induced glaucoma. So to rule out our differentials, we run our following investigations like the anterior segment OCT. But in the anterior segment OCT, we found that there is an increased distance between the posterior surface of the IOL and the posterior capsule with the hyperreflectivity. And there is an anterior bowing of the iris is present, and there is a shallow of the anterior chamber. So we have done a UBM. We done a UBM also test. In that, we also see that there is an anterior pushed intraocular lens with a distended posterior capsule, and there is no rotation of the ciliary body is seen. So we came with a diagnosis of capsular bag distension syndrome. So, and patient was immediately planned for the YAG capsulotomy. Post YAG capsulotomy, intraocular pressure immediately came down to 18 millimeters of mercury, and the vision became 6/18. And the iris bowing was also corrected. So came to this normal position. So thank you.
Wonderful case, Dr. Niharika. Dr. Manushree, your comments?
So in this very interesting session, which is predominantly dominated by surgical interventions, and we had got very good surgical videos indeed. So here our case stresses upon clinical diagnosis, which has to be very accurate to manage the case. So with the detailed history and a very thorough slit lamp examination, we could make some differentials which were missing in the earlier treatment of this patient. So a thorough slit lamp examination made us think about capsular distension syndrome. We backed it up with an ASOCT and a UBM, and we could confirm our diagnosis. A simple YAG capsulotomy gave the patient the relief for which he was
looking for from so many months. So, and we also stress that we often don't have to go for very big interventions like pars plana vitrectomy or maybe AC paracentesis, which have been given in some case reports of capsular distension syndrome. But even a YAG capsulotomy in an OPD setting can give very good results in these patients. So yes, we were very simple with this case, and we again the take-home message is a very good, accurate clinical diagnosis, and for especially the PG students and the initial beginners, a good clinical diagnosis is the first and foremost thing. And over to our state head.
Thank you, Manushri. Thank you, Niharika. And it was really a very excellent example of how clinical examination is the basis of all diagnosis and management. And to begin with, your surgery should be ideal. You should have done a good rhexis, good removal of viscoelastic, so that this situation would not have arisen. But since it has already arisen, it is important to recognize it. Capsular distension syndrome can be early or late onset, and you have to differentiate it from a late onset endophthalmitis, which can be caused by P. acnes, and a YAG in those conditions would have caused problems. But in this condition, as you could have seen that the fluid was relatively clear, we have gone ahead with the YAG cap, and that has given immediate relief to the patient in form of fall of IOP. So the take-home message is keep your surgeries meticulous and your clinical examination perfect, so that you don't overtreat or mistreat a patient.
Yeah, that was a good insight into having a very good clinical examination. So we now move on to the next video, which is from by Dr. Shivani Srivastava. She will be having a video on management of intraocular foreign body. So she is a senior resident at AIIMS Raipur, and the mentor is Dr. Vijaya Sahu, Professor, Department of Ophthalmology, AIIMS Raipur.
Very good evening, everyone. I hope I'm audible.
Yeah,
I
you
hope
are
I'm audible. And
Yeah, you're
my slides-
audible and your slides are visible. Yes, ma'am.
Okay, so a stitch in time saves 9, management of intraocular foreign body. That will be my topic of presentation. So like we all know, intraocular foreign body are a major cause of morbidity, post-ocular trauma, especially in young population, with approximately 65% being in the posterior segment, with vitrectomy being the treatment of choice. So I'm presenting a case of a 9-year boy who had a history of trauma to right eye by metallic object while he was just a bystander and his father was cutting wood. So he presented with best corrected visual acuity of 6/36 with nasal linear scleral tear of around 3 to 4 mm. On fundus evaluation, he had inferior VH and an intraocular foreign body was present in the midvitreous cavity. So we went ahead with our plan of scleral tear repair along with intraocular foreign body removal with the pars plana vitrectomy. We nicely explored the wound, as we can see here, to look for any extension, and the prolapsed vitreous vitrectomy was done. Following which, we sutured it with vicryl suture. We proceeded with a hybrid vitrectomy, 3-port pars plana vitrectomy, and did a good core vitrectomy. Here we can see a vitreous strand that was extending from the scleral tear to the intraocular foreign body, which was gently cut, and triamcinolone acetate assisted PVD induction was done. PVD induction is very important in such cases, and all the vitreous adhesions from the intraocular foreign body has to be removed very nicely. The vitreous periphery was trimmed and PFCL was injected over posterior pole. Now we did a base shaving, and following a good base shaving, we did a sclerotomy in the superotemporal quadrant with MVR blade. We felt that the sclerotomy site was slightly small maybe, so we extended it again, and using an intraocular magnet, we then lifted the foreign body and tried to remove it through the sclerotomy site. However, it got stuck, so we had to use extraocular magnet to gently tease it out. Thankfully, it did not fall down and it came out in just one go. We sutured the sclerotomy sites, and then we did a cryo for any vitreous incarceration at both the sclerotomy site as well as at the site of the scleral tear repair. Once this was done, we aspirated out the PFCL that was there and did a nice evaluation of the retina. We did an endolaser to the pre-existing retinal touches, and then after nice evaluation for any inadvertent break that might have been while removing the foreign body, we closed the case under SF6 gas. So on post-op day 1, the child had visual acuity of 4/60 with a clear lens. However, he started developing posterior capsular opacity and a thick posterior capsule plaque was formed at 3-month post-op period. So we had to, since it was in the visual axis, we had to go for lens aspiration and PCIOL with posterior capsulotomy. The child gained a visual acuity of 6/6 parts on 6 months post-op. These are his inter-segment photos. So I would like to conclude by saying that trauma diagnosis and timely management is important. Thank you very much for your patient listening. Over to my mentor.
Shivani, great job. So I would like to add something about the intraocular foreign body. As we all know, 90% of foreign bodies are metallic foreign body, and out of it, 70% is iron. So once the patient comes to you with open globe injury and intraocular foreign body, thorough ocular evaluation as well as systemic evaluation is mandatory, because some patients, especially with a blast injury, patient may have some serious systemic finding also. So once patient comes to you, extensive history taking is important about the etiology of injury, type of information about the foreign body is there, and whether it is metallic or non-metallic, whether it is inert or organic, and ocular examination, especially for the presenting visual acuity and pupillary reaction, because presence of RAPD and present visual acuity is very important predictor for your post-op visual outcome. And especially, and another important thing about your lens status, about the any signs of any retinal break and retinal detachment. And at this moment, IOP measurement in B scan can be deferred once you have repaired the primary repair. So now there is time for the management parts. Once you're planning for the management, pre-operative planning is very important with planning with all required equipment like magnet and all type of forceps. So in the surgery, you can go in a 1-stage surgery or 2-stage. 1 stage means open globe injury repair with intraocular foreign body removal, or you can prefer 2-stage also when there is a hazy media, especially when there is a corneal bone. Second thing is whether to spare lens or not. So like in our case, lens was absolutely clear, so we prefer this pars plana approach. But in case when there is some injury to the lens, you can approach the anterior route also. Then third thing, in what should be the tamponade for after vitrectomy. So if there is no any retinal breaks, no any retinal injury, you can left the eye with a balanced all solution also. When there is only just a small break and the no other injury, you can also close the case with the air also. But if there is any signs of retinal detachment, you can choose silicone oil or SF6 also, with or without silicone band. So one is a very important thing, that timely intervention and meticulous planning in case of intraocular foreign body is gives you a favorable visual outcome in all type of open globe injury with intraocular foreign body cases. Thank you.
Dr. Meenakshi, would you want to add on some comments?
Yeah, good evening, everyone. Am I audible?
Yes, yes.
Thank you, AIOS, ARC, and WOS for giving us this opportunity. And I congratulate the speaker and the mentor. Just to add that timely intervention is a cornerstone in the management of intraocular foreign body. And lens sparing vitrectomy should be done as much as possible. And minimal intraoperative manipulation of intraocular foreign body should be done in order to avoid any further soft tissue damage. And good post-op assessment should be done to avoid any subsequent post-op complications in either of the eyes. Thank you so much.
Thank you, Dr. Meenakshi. Do we have any questions from the judges? Is Dr. Prashant here? Dr. Tinku, you want to say something? You are muted.
First of all, congratulations for an excellent presentation. The case was very beautifully managed.
I'd just like to ask the mentor, what is your take on the role of intravitreal antibiotics in a case of, retained intraocular foreign body? Should it be given in all cases or no?
If there is any signs of, like you were seeing any signs of infection, increase even cells more than cells 3 plus or 4 plus, or any yellow reflex during examination, definitely you have to give intravitreal injection of vancomycin and ceftazidime. Like in our case, there was no signs of any kind of infection, so that's why we didn't give intravitreal injection.
Thank you. Thank you. Very well managed.
Thank you.
Thank you, Dr. Tinku. We move on to our next presenter, Dr. Deepa Saha. She is from ADA, Diabetes Center and Eye Care, and her mentor is Dr. Apur Bhaumik. And Dr. Deepa will be presenting on cataract in complete typical uveo-retinal coloboma.
A very good evening to all of you and my mentor. I am audible?
Yes.
Yes, you're audible.
Okay, fine. So my case is phaco in eyes with uveo-retinal coloboma. So this is a case of 40-year-old lady with coloboma iris choroid with grade 3 nuclear sclerosis cataract. This is the picture of the cataract and this is the retinal status. Both eye has this coloboma. Now this case seems to be simple, but if we won't be meticulous, we can be in trouble in any of the step. What are the challenges I had to face with this case? It's a moderately hard nucleus. There may be a loose zonules in the area of coloboma. And obviously there is a size of the cornea is less. So shallow anterior chamber is there. So this is my case. After putting the dye, we started with this. I am comfortable access with cystitone, so I know that the faucet is very good here. Most difficult part is the area of glaucoma, where is peripheral is there. And capsule is very slippery. There is always chance of extension. There is extending, but carefully it. I do dissection with very small water with a hybrid nuclear retention should be good. Regarding the nuclear management, I choose here stop and chop technique to give less stress to the zonules with very low parameter, manage the nucleus calcification. Always, whenever coming out, viscoelastics are given, and extra caution should be taken while removing the capsule because many of the time it's very sticky. And you see, the area of colobomatous part, it's really very sticky. So I thought I could help of the simple cannula for controlled removal of the capsule. But the last part, really very difficult. And then I should try to remove the top. Very gently put the I will not directly in the bag so that opening of the haptics can cause more zonulolysis. So I will first put with the simple cannula, I try to remove the cortex. Few cortex removed, but a little bit remained. As I was putting, the bag is coming out. To avoid this, so I kept that cortex. Here I was in a doubt whether to do ETR or not. This is my second post. It was good. Thank you so much. My take-home message is, so whatever the grade of the nucleus is, the nucleus removal should be quick and easy. Preserve the bag, take the help of CTR whenever needed, implantation of the lens in the bag, and if the bag is loose, we have to plan for the secondary IOL. Thank you so much. Over to my mentor, Dr. Apur Bhaumik, sir.
Good evening. It's a nice presentation. Thanks ARC for giving a opportunity to discuss this case. Now this Dr. Deepa is we are lucky. This is a rarest case of coloboma with a cataract presented to us. Most of the cases are presented much advanced cases of cataract. So if you categorize coloboma with a cataract, then there are a few challenges. There's one is a corneal diameter, and second is the hardness of cataract. Third is a zonular laxity or absence of zonule in colobomatous area. And simultaneously, there is a fragile capsules in the case of colobomatous area. You have to careful managing all the cases. So if you want to the diameter of the cornea, so it is very easy to do the phacoemulsification if the corneal diameter is more than 6 millimeter. But if it is less than 6 millimeter, it is a really challenging, and sometimes is a fail to do the phacoemulsification. You have to convert into SICS. And if it is less than 6 millimeter, even to try the phacoemulsification, better to go for the scarocorneal tunnel, because if you give to at least 2 millimeter width of the clear cornea or 2.2, it is yeah, it is almost go to the center of the cornea. So it is better go for the scarocorneal tunnel. So better approach.
नानी को पानी दो please.
So, and come to the hardness of cataract. If your hardness of cataract sometimes it looks like a grade 3, but when you enter in you do the sculpting, you get it is more than more than it is. It seems to be in our clinical examination. So you should be prepared for that. And for the zonular laxity and zonular fragile capsule, you never put any kind of capsular hook in the area of colobomatous area. It is better to put side of both the colobomatous area, because if you in the most of the cases this patient has the fragile capsule in the area of this colobomatous area. So if you any traction in the capsular rhexis margin, it is can give way. And it's really tough. It is, as I said, if it is less than 6 millimeter diameter of the cornea, but if it is more than 6 millimeter, you can go for phacoemulsification. And put everything in hand, CTR or CTR segment, if you try to fix the capsular bag. And if cannot secondary do the put the IOL, it is better to plant secondary IOL in the second sitting, not the first sitting. Thank you so much.
Thank you, Dr. Arup. Comments from the state head, Dr. Sudipta Ghosh.
Good evening, everybody. Thank you so much for this opportunity. Excellent surgery done by Dr. Deepa Shah, and Dr. Arup Bhomik is one of our prolific surgeons in West Bengal, known nationally also and internationally. So the tips they've given by Dr. Arup Bhomik was very important. One more thing is, when the eye is small, usually inserting a intraocular lens inside the in such cases could be difficult. So sometimes we have to give away one of the haptics so that the IOL is settled down. And vision rehabilitation in such cases is also important. So regular follow-up visits for this patient and to see how much of vision they have got post-operatively in after the surgery is also of prime importance. But the fact is, in such cases, earlier detected, if cataract is around, say, grade 2 or grade 3, it is better to always get a cataract operated earlier rather than in a hard one. And in such cases where the cataract is hard, where your nucleus grade is 4, it's better to go for an SICS rather than, being mastering the phaco in such cases. But Dr. Deepa managed the case very nicely. Thank you so much.
Thank you. Thank you, Sudipta Di, and thank you, Arup sir.
Thank you. Thank you.
I have a question. Like,
Yes.
will you consider 4-through pupilloplasty?
Yes. Could be good. So
About
depending
better,
on
because
the
you have got a chance. So
I generally don't prefer for orthoplasty in that area because in that area actually in the where the iris is absent there is a retinochoroidal coloboma, so there will be no glare actually in that area. If the patient has a normal retina without any colobomatous area in the choroid and retina, only in the iris you can consider orthoplasty, pupillary reconstruction. But otherwise, it is better not to do because most of the cases you may need the careful retinal examination, and you may need laser photocoagulation around the colobomatous area to prevent the retinal
That's a
detachment.
great point. Great point. Thank you, Arup.
So let's move on.
Thank you
The
so
next,
much, everybody.
Thank you.
yeah, so the next presentation now is by Dr. Nisha Jha. She'll be presenting on iris claw lens. She's a senior resident, RIO Patna, and the mentor is Dr. Anita Ambasta from RIO Patna. So Dr. Nisha.
Am I audible, ma'am?
Yes, you are. Yes, you are.
Okay, ma'am. This patient was a 77-year-old female who presented to me with both eye advanced IMSE, and she had gross phacotonosis with bag weakness. So I had planned and she had pseudo exfoliation. So I had planned an ICC with iris claw. But during my nucleus delivery, the tunnel was short. So while extending my tunnel, I had a side cut at the nasal tunnel. So while injecting viscoelastic from the side port, I had an iris prolapse, and now my iris has become floppy. So I tried repositing the iris back and completed my nucleus delivery with the help of like this. I completed the nucleus delivery. Then I started with my automated anterior vitrectomy bimanually. So there was not much iris in the pupillary area. I just cleared the little iris, the little vitreous stand I could see. I was clearing it with my manual automated vitrectomy. But again, as you can see, I had an iris prolapse because my wound was not stable. It was leaky, and iris again came out. So I stopped with my vitrectomy because there was not much vitreous, and I removed the remaining epinucleus with the help of visco. This remaining epinucleus was removed with the help of this. Then I placed my iris claw IOL and put it in AC. Then I made it horizontal with the help of a IOL dialer. Then I held the IOL. Then I injected visco over the optic. And I held the IOL with a lens holder, and with a pronating posture, I slipped the haptic under the iris and lift it. And with the other hand, I hooked the haptic under the iris, and you can see the enclavation mark. Then again, with my non-dominant hand this time, I held the optic with the IOL holding forceps and enclaved the other end. We can see it is nicely centered. Then I did a peripheral iridectomy with the help of a cutter, vitrectomy cutter. Then finally, I sutured the wound and closed the case. Thank you. Over to my mentor.
Yeah, thank you, ARC, and thank you, Wos, for this mentor-mentee program. And this video is about iris claw lens and not about the iris prolapse. This was probably made for another presentation. So we're just going to focus on the iris claw lens. And iris claw lens implantation is a simple and easy technique, which I feel should be mastered by anybody who is doing anterior segment. Easier than putting a SFIOL and having less complications than a ACIOL. So this is indicated whenever we have loss of capsular support and xenular support, if there is any complication during a phaco surgery, or whenever we want to do a secondary IOL implantation in case of aphakia due to whatever reason. And this can be retropupillary iris claw, or there can be a prepupillary. Of course, there are advantages of using a retropupillary. There's less chance of endothelial damage and CME and a pupillary block. And although PI was not, many people would not be advocating a PI, but at our place, we like to do a PI, sort of to be on the safer side. And when not to be using this, if you have iris atrophy or a patient of uveitis or even chronic glaucoma, and in those patients, we don't like to use this, the iris claw lens. And post-op, of course, there can be disinclavation and maybe a decentration, although it's not that common. And uveitis, glaucoma, hyphema theoretically, and we have not come across any single case like that in our cases. CME is one thing we do look out for post-operatively. So all in all, I feel that this is a good procedure, simple procedure done by Dr. Nisha herself. You can see that she did have a little bit of problem making that tunnel, but she did manage a very nice iris claw lens, and she does these cases a lot. And so it suffice to say, it's if you know SICS, you can do this. And the learning points would be, of course, that while when you're using the Sinski to tap the iris to enclave, don't push too much of pressure by the Sinski, otherwise there can be extrusion of the claw. And using, if you take in too much of iris also, that can lead to ovalization of the pupil. So I think that this all comes with practice. Thank you.
Comments from Dr. Anjana Kumar, State Head.
Yeah, thank you, Dr. Anita and Dr. Nisha. This was a simple but a real life scenario of how a resident goes to learning a new skill with all the complications that surround it and the struggles that she has. Cataract surgery continues to be the most commonly performed ophthalmic procedure, and an anterior segment surgeon needs to have a backup plan to deal with such scenarios. This video was meant to highlight the utility of an iris claw lens, especially for those surgeons where you do not, anterior segment surgeons, where you do not have a retina backup, or your referral to a person is not easy, and you want your patient to go out of the OT with an IOL in position. Of course, your decision-making depends on the level of skill that you have and the instruments or the accessibility to an IOL in the OT, as well as the ocular status of the patient, and depends on what is your comfort zone and the ocular status, of course. So an iris claw lens with a scleral tunnel lets you control the refractive outcome, and despite a 5.5 millimeter incision that you need for this, you can still have a workable result that would be acceptable for the patient. The disinclination, if it happens, which is one of the common complications that you encounter, at least a reinclination can be done, and it is more commonly encountered in the young patients or in the post-traumatic cases. You have to look out for any atrophic iris, or your case selection should be good. And endothelials, and if you compare it to any other option, such as an ACIOL, which we have been doing as anterior segment surgeons so far, the endothelial cell loss and the positioning of the endothelial cell loss is, of course, comparatively less, and the positioning of the lens behind the iris gives you the result that and the cosmetic outcome that you want. Thank you.
Thank you, Dr. Ranjana. Do we have any questions from the judges? I think we'll move to the next presentation. We are running out of the time. Next presentation is by Dr. Navreet, who is first year resident from Adesh Institute of Medical Sciences and Research. And her mentor is Dr. Rajwinder Kaur. She is professor and head. And Dr. Navneet will be presenting a surgical video on Phacomorphic glaucoma in a case of aniridia in a young male. Dr. Navneet.
Good evening, everyone. My case is, I'll be discussing 31-year-old male patient presented to us with the diminution of vision in both the eyes since childhood. Ocular examination was done. Uncorrected visual acuity was hand movements positive with increased IOP, and mild corneal haze and limbal stem cell deficiency was seen in both eye. Megalocornea was there, and aniridia in both the eyes, and lenticular coloboma inferiorly present with the congenital cataract with Phacomorphic glaucoma. I'll be showing you the surgical challenges in this case, which is temporal SSA with aniridia IOL. So there was mild corneal haze was present. There was limbal stem cell deficiency. So for the better visualization, capsule staining was done, which aids the visualization. High viscosity OVD was used for the, stabilizing the capsular surface and for the better visualization. So here comes the real challenge of our case, that was capsular access, as the cataract was fluid filled and absence of the nodules in 2 clock hours inferiorly. So low infusion was preferred. So it also reduces the intraocular turbulence and protects the corneal endothelium. So you can see the hustle while performing the capsular access. So very, very gently, we finish this step of capsular access. After that, main incision was widened for the implantation of aniridia IOL. Despite of absence of the nodules in 2 clock hours, zonulus port was good enough to put IOL in the sulcus. So this is a picture of post-op with vision 612. And this is the journey of from 6 hand movement positive to 612. Thank you for watching. Over to you.
Case. Dr. Rajvinder,
Over to
please.
you, Dr. Rajvinder Kaur, my mentor.
Okay, I'm audible?
Yes, you're audible.
Thank you, Dr. Shweta and Prashant Bakulne for giving this opportunity. So it was a very rare case. In my lifetime, I have operated such case for the first time. So aniridia is you have to be very careful because it is a bilateral and it is usually associated with systemic manifestations, such as it has the 3 components. It can occur like in 3 component classification can be 3: autosomal dominant aniridia, sporadic cases where it is associated with Wegener syndrome, that it can have in 30% of the cases it can have Wilms tumor. So it is very important to identify the Wilms tumor to save the life of the patient. So the glaucoma is mostly commonly seen in 75% of the cases. First of all, we can have the open angle glaucoma. In few cases we can have the angle closure glaucoma also. So in 75% of the cases there are chances for the glaucoma. The next. So the commonly associations are the glaucoma, nystagmus, corneal haze, microcornea and megalocornea. They both can occur. But in our case, we had glaucoma, corneal haze, megalocornea, that is around 15 mm of the cornea in both the eyes. And aniridia associated keratopathy was also there, and patient had the severe dry eye also. He was put on lubricants also before the operation. So 360-degree peripheral conjunctivalization of the cornea. So that was evident to show the limbal stem cell deficiency. So the absent zonules in 2 clock hours, but despite of the good zonular support, we decided to put the aniridia IOL in the sulcus. And congenital, that is cataract with the Phacomorphic glaucoma. Next. So the commonly association patient may have the foveal hypoplasia. If they have hypoplasia foveal, they have the poor vision. But in our case, the vision was good. Patient may have optic nerve hypoplasia, fundal coloboma. It was absent in our case. So in few cases, the Gillespie syndrome, patient may have mental retardation, auditory dysfunction, and Wilms tumor and genitourinary anomalies and the endocrine dysregulations. So it is very important to have a take-home message. The next slide. So the family history is very important. Systemic evaluation to rule out any associated ultrasound abdomen, that is abdomen, is very important to go for annual to detect it at the earliest. So intraocular pressure should be checked in all cases every 3 months. Thank you. Over to you, Dr. Malli.
Yes, very nice presentation. First of all, I want to, can you stop sharing the screen? Yeah. Yeah. First of all, I want to congratulate AIUS ARC platform to help us all connect with each other from all over India. And I, being a vitreoretinal surgeon, I'm really happy to see the plethora of cases, beautiful cases from each and every subspecialty of ophthalmology. And personally, I have learned a lot. Definitely, all the credit goes to AIUS and WOS for this. And this is a wonderful case. Dr. Rajvinder has managed it really well. Like aniridia being uncommon, one should be at least conversant with the possibility of zonular dehiscence, chances of glaucoma, presence of retinal problems. So B scan should be done beforehand to know the status of retina, and afterwards OCT should be done to rule out foveal hypoplasia. And peroperatively, as she has rightly said, that capsular access should be done very carefully. One should take all the precautions to prevent any posterior capsular tear. So it has to be very slow and gentle, like she was doing. And at time in between, she used, I think, scissors also to complete the cut, so that this should not go behind and PCR should not happen. So because once there is PCR, the risk of retinal detachment goes high, the risk of glaucoma becomes more. It is already a difficult case, becomes more difficult. So she has done it in a right manner. And then while putting, I think one important point, because she was keeping this IOL ready. Aniridia IOL is a big lens. So if there is significant zonular dehiscence, then one should go with scleral fixation. And I think in such cases, one should make the scleral flaps beforehand, so that after surgery, once you have already made a big limbal incision, it becomes difficult to create scleral flaps. So you might not need it later, but that can be one point which can be considered. Otherwise, overall, very nice presentation, very good case, and very good association she has shown. Her case had corneal problem, limbal stem cell deficiency, and complete aniridia. And gonioscopy should be done to see the state of the peripheral iris. She had little bit of a small iris chunk in the angle. So these patients should be followed up very closely for the glaucoma. Yeah, I think that's all. Thank you.
Thank you,
Anything
Dr.
anyone else can add, because I generally don't do anterior segment surgery. So anyone, any of the seniors, they are welcome to give their inputs.
Any comments from our prolific anterior segment surgeons that we have here? Dr. Anagha. Okay, so let's move to the last video of the day. This is by Dr. Smriti, who is going to present on corneal neurotization from LV Prasad Eye Institute, Bhubaneswar, and the mentor is Dr. Sujata Das. Yes, Dr. Smriti, over to you.
Thank you. Probably I'll have some. See the slides.
Hello everyone, I will be discussing a case of corneal anesthesia following varicella zoster infection managed successfully by indirect corneal neurotization technique. A 24-year-old female first presented to us in 2007 with chief complaints of white spot on the black portion of the right eye since childhood associated with on and off redness. There was history of chickenpox infection during childhood. Visual acuity was counting finger close to face and cornea showed a hypertrophied vascularized scar. The patient again presented in 2019 with pain and redness of 1 week duration. There was minimal conjunctival congestion and cornea showed a scar with an overlying epithelial defect. A diagnosis of neurotropic keratopathy stage 3 was made and corneal scraping and glue BCL was performed. At 1 month post-op, a central vascularized leukomatous corneal scar was noted. The corneal sensations were completely absent. Considering the prolonged history and clinical findings, corneal neurotization by the indirect technique was planned. The corneal sensations were checked, followed by checking the dermatome supplied by the nerves. Dissection and mobilization of the sural nerve was done. Then the contralateral supratrochlear and the supraorbital nerves were isolated and they were identified. Subcutaneous incision was made and a tunnel over the nasal breech was constructed to the ipsilateral eye. The sural nerve was passed through this tunnel. Further, a blepharotomy tunnel was created and the nerve was passed into the superior conjunctival fornix and further to reach the perilimbal area. The nerve was dissected to expose 4 to 6 fascicles. A 360-degree peritomy was done and a sclerocorneal pockets were made 1 mm into the cornea. These nerves were then dissected at appropriate length and passed into the sclerocorneal pockets. Fibrin glue was applied and the conjunctiva was closed using 80 vicryl sutures. The other end of the sural nerve was dissected and end-to-side anastomosis with the supratrochlear nerve was performed and the blepharotomy incision was closed. At 1 year post-neurotization, the patient reported that she could appreciate the installation of eye drops in her right eye. From the date of surgery, she had had only 1 episode of epithelial breakdown which was managed conservatively. Sensation has increased in all quadrants ranging from 25 to 60 mm except the center. Vision potential checked with scleral lenses improved from counting finger close to face to 20 by 320 and we have discussed with her the option of lamellar keratoplasty for further visual rehabilitation. Corneal neurotization addresses the underlying pathophysiology of neurotropic keratitis and can be considered as a preliminary step before further interventions such as keratoplasty. Hello everyone, I will be
Thanks ARC and Wos for organizing such a nice video session. Actually, this patient was seen by me first in 2007 and I was the one who did keratectomy because it was a hypertrophic scar. And Smriti did excellent surgery and you can see the sensation has improved and the epithelial breakdown incidence has decreased. Even Cock-A1 aesthesiometer has the sensation has increased. So I think the indication is not a large number of patients will require this, but whoever need this is the most effective way of dealing. There are a lot of newer pharmacotherapy like insulin-like growth factor, but all those are not taking care of the primary cause. There are maybe a lot of recurrence if we use the pharmacotherapy. So this is definitely a promising and evolving technique to take care of corneal neurotropic, especially I feel this congenital anesthesia and most common indication if you see HSB or HZO neurotropic cornea, especially when we are planning for corneal transplantation, we can do this and later on we can plan. Otherwise, you'll end up with a lot of consequence of neurotropic cornea like corneal melting. So there are direct and indirect approach, but mostly sural nerve is the most common like Smriti showed here. And this is not only cornea surgeon, this is a more specialty other than cornea. Plasty, sometime we took help of plastic surgeon who took the sural nerve. And usually it takes few months from you do the surgery, and it takes 3 to 6 months to get the sensation, and slightly longer time for the confocal microscopy. Although the patient can feel the, like you put the drop, patient can feel the sensation. But confocal is one of the surrogate, not surrogate, the measures, actual measures to know whether the nerve is growing or not. So I feel this technique has a long future and promising for people who are suffering from neurotropic cornea.
Yeah, so to sum it up for Team Odisha, this is seems to be a very promising technique, and we do have a large number of patients who have neurotrophic keratitis. Important is to identify which one of them will need. Earlier, since 15 years of its development, it has been reserved for very bad cases of like stage 3, but even bad stage 2 cases can be taken up for neurotization. And like Dr. Sujata also mentioned, growth factors have been developed, but they're very costly. And in the Indian scenario, I think this is a very viable technique for all these patients. Thank you, ARC and WS, for this opportunity.
Yeah, great. So after this fascinating video that we just saw, we come to the end of this enriching webinar. So while our judges are busy compiling the results, maybe we can have some comments from our judges until the results are out, for which I'll invite Dr. Tinku Bali, Dr. Anaga, Dr. Basak sir, if they are also there for the results. And any comments?
Well, I'd just like to compliment all the presenters for the excellent presentations. I mean, they were all very interesting, challenging, and they drove home the learning points extremely well. I mean, such short videos, but they managed to show the key point so well and, so clearly. I personally learned a lot, and I'm sure the audience and all of us who've been a part of this webinar are going to go home more learned, this evening. And a big thank you on behalf of ARC to all the mentors and all the discussants who, put in their learning points and their comments and perspectives and added to the whole thing. Heartfelt thanks also to Dr. Samar Basak sir, who's been with us here this evening. He also, gave us some very insightful comments, and that really added to the, learning in the whole webinar. So, Dr. Shweta, have you compiled the results?
Hi, everyone. Yeah. Hi, everyone. Can you hear me? Hello?
Yes, yes. Dr. Anaga, we can hear you.
Yeah, sorry, there could be some background noise and traveling. But just wish to thank each and everyone here for the excellent presentations, excellent discussion, right from Dr. Samar Basak sir, shared his valuable time, Dr. Namrata Sharma ma'am, who in spite of their busy schedule, they could, be here and give us their input. I think all these great heads for today that we could take on big, deep gratitude from the AIOS ARC team. On behalf of Dr. Prashant also, thank you, Wos. Thank you, Dr. Mohita ma'am, for collaborating with us and bringing out such a wonderful video-based program. Thank you once again.
So, I have the results with me, and Dr. Shweta, should I announce the results now?
Yes, please. Yes, please.
So we have some,
Samar sir,
it's very
Samar
difficult
sir.
to announce the results because today I think.
Excuse me, ma'am. If
Yeah.
before the announcement of the result, can we all have our cameras open and can we have a click a group photograph? Results के बाद सब बाहर जाएंगे इधर-उधर.
Correct. Very
So
correct.
we can have a group photograph if everybody agrees to switch on their camera. It's such a wonderful webinar. We should have memories of it with us.
Yes, I think we should do that. Yeah.
Kasturi ma'am, if you are there, please switch on your camera. I think many have left probably.
No, she's in a state conference.
Okay.
Dr. Kasturi.
Sorry for interrupting, but I thought this was important. चलो खींचो photo.
Thank you. So, I feel that everyone tonight was a winner. Everyone presented so well and everyone, came out top notch. But, for the sake of announcing, we have to announce the prizes. So since we have cash prizes of 10,000, 7,500, 5K and 2.5K. So we have the results from the judges and I'll be reading them out. So I'll be reading them out in reverse order. The fourth position goes to the team from Andhra Pradesh, Dr. Harika, Dr. Y. Sujata, and Dr. Madhavi. Congratulations. Third position, give them a big hand, please. Yeah. So third position goes to team Assam, Dr. Vatika Bharadwaj and Three cheers, Dr. Kasturi.
Thank you so much. I'm in a different program now, but thank you so much. I could hear the good news.
The second position is Team Telangana. That is Dr. Snehal Panpate, Dr. Charuta, and Dr. Alpa Atul. Huge congratulations to the whole team.
Thank you. Thanks a lot.
And the winner, the team at the first position, is Team Odisha. That's Dr. Smrititi, Dr. Sujata Das, and Dr. Devi Aishwarya Das. Huge
Thank you so much. Thank you so much.
For that
Your patience paid off.
Yeah, thank you.
I think so.
Thank you so much.
So
Smriti, congrats
to everyone. Yeah, huge
Hearty congratulations to everyone.
Congratulations to everyone.
Congratulations to all.
Thank you.
But like I said, all of it, I think every case was so well presented and great learning in every case. So everyone came out a winner. And I think with that, I would again like to thank our excellent moderators, Dr. Shweta Walia and Dr. Aditi Agarwal, for, carrying forward this program so smoothly. Thank you all. And with that, I hand over the proceedings again to Dr. Shweta and Dr. Aditi for the final conclusion.
Dr. Aditi?
All right.
Closing remarks.
All right. So with this, after all the beautiful videos and also the judging and having the results, I think that is the results and all are just a formality, but we know that everybody has done a fantastic job. Everybody has taught us so much today. So we come to an end of this enriching webinar. And as we said that everybody showcased the best of their talents. And we also saw the vital role of our mentor-mentee relationship in advancing ophthalmic care. I extend all my gratitude to all the presenters, mentors, state heads, and most importantly, the audience. Because without the active participation of audience, the work and the job is always incomplete. So we look forward to seeing you at the next event very soon. Let's hope to have a good meeting once again. Thank you, everybody, for such a fantastic evening and for being there up to the end. Thank you so much.
Thank you.
Thank you.
Thank you.
Good night, everyone. Thank you. Good night.
Thank you. Thank you to each and every